Hey, so good morning or good afternoon, everyone. Welcome. And today we're going to be discussing uncertainty and limitations of evidence in health technology assessment. We can consider this to be one of the most important topics in this course, primarily because in real world healthcare decision making, we almost never have perfect evidence. So, by the end of this session, you should be able to explain the different types of uncertainty in clinical evidence, differentiate subgroup analysis versus heterogeneity, compare randomized clinical trials and real world evidence, identify common misinterpretations in research, and hopefully apply these concepts to HTA and universal healthcare decision making. So, this lecture is not just theoretical. This is directly tied to policymaking decisions. So let's first look at the big picture. Why does all of this matter? So, health technology assessment is fundamentally a practice of decision making under uncertainty. So, no evidence is perfect. Also, no study is perfect. Evidence is always incomplete, but decisions always need to be made. So the key mindset here is that we're not choosing the best truth, but we're choosing the best available decision. And this is what separates your HTA from pure research. Now, where does uncertainty come from? So let's break it down. Saan ba nanggagaling ang uncertainty? Una, limited sample sizes. Hindi naman kasi lahat ng tao sa population kasama sa isang study. Usually, selected group lang. So, dun pa lang, may uncertainty na. Pangalawa is study design limitations. Even RCTs, which are considered gold standard, there are still biases. Biases can include selection bias, measurement bias, or attrition. Third, variability in patient populations. Hindi po pare-pareho ang ating patients. Iba-ibang age, comorbidities, genetics, adherence. Kahit po iisang gamot, iba-iba rin naman ang ating response. And fourth, this is the most important difference between real-world and trial settings. May pinag-aiba kasi sa trials, controlled environment, monitored yung patients, strict yung protocols. Pero sa real world, may nakakalimot uminom ng gamot, may hindi afford ang gamot, at merong access issues. So kahit maganda ang results sa trial, hindi ibig sabihin ganun din nakalalabasan sa actual practice. That's why we say even high quality RCTs do not eliminate uncertainty. So next, we have the types of uncertainty. So let's organize this. Pag sinabi nating uncertain, we can classify it better into 4 types. Una, parameter uncertainty. Ito yung pinaka-familiar sa atin. This refers to the variability of results. For example, there's a difference in effect size, confidence intervals. So pag nakikita nyo na malapad yung confidence interval, mataas po ang uncertainty nun. Pangalawa po, structural uncertainty. Ito po medyo mas abstract. This comes from assumptions in models. For example, ang pinili ay disease progression assumptions compared to transition probabilities. So, kung mali yung assumption mo, kahit perfect yung data mo, possible na mali talaga yung iyong conclusion. Third is methodological uncertainty. So, it depends on how the study is done. An example is payer versus societal perspective and time horizon. Kung short ba ang tinitingnan or lifetime yung pagbase ng isang study. So kahit po same yung data, different methods, possible na iba talaga yung conclusions. And yung pang-apat, generalizability uncertainty, this is the most important. The question always here is, can we apply this to the Philippines? Kasi ibang healthcare system, iba yung budget, at iba din yung population. So kahit pa valid yung study abroad, hindi automatic na applicable here sa Philippines. So remember that hindi lang uncertain ng evidence. They have their each type, and each one can affect decision making differently. So let's have a quick application of the things we talk about. So check this result. Tingnan nyo yung RR, tingnan nyo yung ating CI. Effective ba ito yung treatment? Ngayon, if tinignan nyo, mukhang effective yung treatment kasi yung RR naman 0.75. Pero based on the study of our bias statistics last time, tingnan nyo yung CI, lumalampas ng 1. So possible na walang effect, possible na merong effect, at best possible na negative yung effect. So the correct interpretation here is we're not sure, or there is a large uncertainty in this example. So hindi natin pwedeng sabihin confidently na effective siya. Possible na effective, pero possible din naman siya makasama. Next, we have our subgroup analysis. So subgroup analysis means paano hinahati yung patients natin into smaller groups. So dito kasi, you could subdivide your whole population into age groups, severity levels, or comorbidities. The goal is simple here. Kaya ka nag-divide into subgroups para makita mo sino ba ang nagbe-benefit sa inyong treatment plan. Sinong pinaka nagbe-benefit. And this is very important in HTA because instead of saying the drug works for everyone, we can say the drug works best for this group. And that is more realistic. Okay. So, bakit po important ang ating subgroups? It is important, for example, mahal yung gamot. Okay, mahal yung gamot na, alam natin effective pero mahal yung gamot. Pag binigay natin sa lahat, possible na hindi siya cost-effective. Kumbaga, if there are better alternatives for patients who are less sick, mas matipid kung ini-stratify natin ang gamot. Pag binigay natin siya only sa high-risk patient, then it becomes cost-effective. Kaya po, doon ang gagaling minsan yung policy decisions na sinasabi only use in high-risk patients or restricted use for high-risk groups. So, sa subgroup analysis, it helps us target treatment, improve efficiency, and maximize values. So, this is actually how real policies are made. Hindi lahat ng gamot one size fits all. Next, we have our subgroup pitfalls. Dito po yung yung flaws or possible flaws ng ating subgroup analysis. Una is post hoc analysis. Hindi planned yung analysis. So, ang sabihin po nito, ginawa lang yung analysis na yun pagkatapos makita ang data. So, parang naghahanap ka lang ng interesting result. Pangalawa, small sample size. Pag hindi balance yung iyong population na inaral, kokonti lang yung patients per subgroup, unreliable po yung results doon. And pangatlo is multiple comparisons. So, the more groups you analyze, the higher chance na may lalabas na significant by chance lang. So, possible na false positive yung mga lumabas. Kaya, ingat din po tayo sa ating post hoc analysis. So, the more you slice the data, the more likely you find something by chance. So, usually, ginagawa ito ng mga naghahanap ng positive result. Kaya, yun, ingat lang po tayo dyan. Sunod po is heterogeneity. Let's now move to heterogeneity. So, heterogeneity is variation in treatment effect. Nakakalito din po ito minsan kasi yung subgroup analysis, yun yung hinati natin intentionally yung ating population. Pag heterogeneity, it is the natural variation of a population size. So when we say heterogeneity, the treatment effect is not same across all situations. Nagbabago yan sa iba't ibang patients' characteristic, clinical settings, or study design. So even if a drug works overall, it might not work the same for everyone. So example, a drug might work well in younger patients but less effective in the elderly. That is heterogeneity. And because this is very important for HTA, it is important because HTA decisions must apply to the population, not only in ideal conditions. Next, you have the different types of heterogeneity. So let's break down heterogeneity further. So there are three main types that you need to remember. First is clinical heterogeneity. Ito yung differences in patients. For example, age, disease severity, or comorbidities. So kahit po same drug, iba-iba rin yung response. Pangalawa is methodological heterogeneity. Ito naman yung differences in study design. For example, pinag-compare natin ay RCT versus observational. Ay magkaiba po talaga yun. Second is different outcomes measures. Pangatlo is different follow-up periods. They can change the results because of different methodology. Pangatlo is our statistical heterogeneity. Ito yung measurable differences in results. So usually you'll see this as I squared or I raised to 2. The higher the I squared, the more inconsistent the results across studies. So the higher it is, the more inconsistent it is. So quick summary, clinical is differences in patients, methodological is difference in design, and statistical is differences in result. You don't need to compute I2, but you need to understand what it means. So why does heterogeneity matter? The easiest answer is because real life is not uniform. In clinical trials, controlled an environment, selected yung patients, but in real life, iba-iba yung patients, iba-iba yung settings. So even if a drug works in a study, it may not work the same in the real world. And remember, HTA decisions apply to populations, healthcare systems, and national policies. So hindi lang ideal patients in trials. And if you ignore heterogeneity, you risk making decisions that don't work in real-world settings. Now let's move on to a very important comparison. RCTs versus our real-world evidence or our RWE. So randomized clinical trials or RCTs, these are highly controlled, randomized, and designed to minimize bias. So they have a high internal validity, meaning they have strong confidence or katiwa-tiwala na yung effect no na-observe nila is due to the drug. On the other hand, yung ating RWE or our real-world evidence, it comes from actual clinical practice. It includes real patients and it includes real behaviors. So it has high external validity, meaning it is more applicable to real life. So both are important, but they serve different purposes. Okay, let's continue. So here is a comparison between our RCTs and our real-world experience. So RCTs, high control, low bias, artificial yung setting. So RWE, less ang control, higher yung bias, pero real-world yung setting. So yung trade-off talaga natin here is RCT is accuracy of the cause. Alam natin na yung gamot talaga yung nagbibigay ng effect. Pero yung RWE, the relevance to reality, yun yung mapapansin natin kung gumagana ba siya or effective ba siya sa tunay na buhay. So in HTA, we don't actually choose one over the other. And we tend to use both. If you only rely on RCTs, you may ignore real world problems. If you rely only on RWE, you may accept biased results. So balance is key. Okay, so the key insight here is regulators often ask, does it work? So hinahanap natin is our randomized control trials. Ang atin naman, HTA, inaalam natin kung gumagana ba siya sa tunay na buhay and kung worth ba yung babayaran natin. So sa HTA, it considers effectiveness, not just efficacy, cost effectiveness, affordability, and system impact. So a drug can work, but a drug might still not be worth funding. And that is the reality of our healthcare systems. Lagi naman kasing kulang ang budget natin, pero our needs of healthcare is always unlimited. So always remember that HTA is not just about the science, but it's decision making in the real world. So take for example, here's an example. Sa RCT, mataas ang adherence, pero sa real world, mababa ang adherence. Kasi sa RCTs, ang patients natin closely monitored. Kaya meron ka mga trial staff. Pangalawa, regular yung follow-ups and they are actively reminded to take their medication. Kaya mataas po ang kanilang adherence. Take for example, 95%. Now, sa real world, possible na nakakalimutan uminom ng gamot, may side effects na hindi nire-report, or minsan, hindi lang talaga afford ang refill. Kaya nabagsak ang ating effectiveness, so around 60%. So, what happens to effectiveness? It decreases. Kino-combine kasi, hindi lang naman kasi yung clinical effect yung tinitingnan. Yung effectiveness is also gaano kaganda yung magiging effect sa yung effect as a whole. So, which should we base our decision on? So, the answer is not only one. We need both RCTs and real-world evidence. So, let's move to common misinterpretations. These are mistakes that even professionals make. So you need to be very careful on handling these things. So the most common ones are confusing statistical and clinical significance, misinterpreting relative risk, or overtrusting subgroup findings, and ignoring confidence intervals. If you understand this part, you will avoid most interpretation errors. Una, statistical versus clinical significance. Pag sinabi natin statistically significant, like in our biostat, the result is unlikely due to chance. Meaning, pag mas mababa siya sa 0.05, hindi tsamba. Pero ang problema nun, hindi sabihin na malaki or maganda yung effect. So statistical significant does not automatically mean clinical significant. So for example, nababa yung blood pressure ng 1 millimeters mercury. Well, with an enough sample size, possible nga makuha yun at statistically significant. Pero, clinically, wala yun. Like, ikaw, bumaba ng 1 mmHg. Parang uminom ka ng gamot. Parang sayang naman yung gamot. So, statistical significance doesn't really actually mean clinically meaningful. So, always ask, does this result actually matter for the patient? Sunod, absolute versus relative risk. It's another common trap. Relative risk often makes results look bigger because it's a larger number. So, pag sinabing 50% reduction in risk, malaki, di ba? Parang, okay. Ang laki, 50% reduction. Pero pag sinabing absolute risk, yun talaga yung mas magandang tingnan. If the baseline risk is very low, example lang, ARR mo ay 1%, ang number needed to treat mo is 100. So, you need to treat 100 patients to benefit one. So, malaki yung relative impact, pero yung actual impact ay mababa. So, usually, relative risk, it's for storytelling. Pero absolute risk tells the reality. Kaya nga po, ang tinitingnan natin ay pareho. Okay, let's continue with our confidence intervals. So, confidence intervals tell us about precision. If the CI is more narrow, mas precise yung estimate. Pero pag mas malawak yung ating CI, mas uncertain. If the CI includes the no effect value, so pag nag-cross siya ng 1, the result is inconclusive. So kapag po kapag ang ating study ay tinitingnan, hindi lang natin tinitingnan yung estimate. We always check how precise is the estimate. So, would you base a national policy on an uncertain result? Siyempre, hindi. Kaya, ang ating confidence interval ay importante pag tinitingnan natin sa HTA. Ngayon, balik tayo sa subgroups, pero tingnan uli natin from a more critical perspective. So, ang isa kasing nakikita is kapag may subgroup analysis, usually, ina-assume na tama kasi na-publish eh. So, it's not true. It's not always true. Kaya, kailangan mong maging maingat pag tinitingnan natin ang ating subgroup analysis. You should be very cautious especially if yung subgroup analysis is post hoc, meaning after the fact na lang ginawa. Mababa yung sample size or there is no clear biological explanation how that happens. Kasi in most of the cases, tsamba lang talaga yung subgroup findings or it could be just random noise. So not all subgroup results are real and some are just simply statistical accidents. So always ask, was the subgroup interpretation planned before the study? Is the sample size adequate? And third, does it make clinical sense? Another issue that you may encounter is RCTs in overconfidence. So, RCTs are the gold standard. Yes, tanggap natin yon. It is very rigid. But they are not perfect. Remember that our RCTs, these are very controlled, selective, and artificial. And they often reflect or exclude elderly patients, patients with multiple diseases, or patients with poor adherence. So while they can tell us, can this drug work? They don't always tell us, will this drug work in real life? RCTs can show potential, but real world data shows reality. So we don't rely on RCTs alone. Finally, let's bring this into the Philippine context. Kaya tayo nag-AHTA, it's because we need to make decisions. And in UHC, evidence must be applicable, affordable, and equity. So, ang isang example nito is, meron ka isang study na basa na kinonduct sa US. It is very effective in the US. However, in the Philippines, it might not translate that well because it might be too expensive, or it requires frequent and expensive monitoring, or it might not be widely accessible. So, should we fund it? Titingnan. Hindi natin sigurado. Kailangan pag-aralan. So, good evidence is not enough. It must be relevant to the local context. And that is where HTA analysis comes into play. So, how does HTA approach uncertainty? Remember that HTA doesn't eliminate uncertainty. That's impossible. Hindi po possible na mawala ang uncertainty. Lahat ng study sa mundo, there's a bit of uncertainty in it. So instead, it manages our uncertainty by using multiple sources of evidence, including real-world data, clearly stating the limitations of the study, and making transparent decisions. So instead of hiding uncertainty, HTA must declare it or make it explicit to the decision makers. So a good HTA report doesn't pretend to be certain. However, it must clearly explain how uncertainty is, and that is what makes decisions credible. So let's be honest, HTA decisions are never perfect. Like, laging may magrereklamo or may magkriticize. These are not final. These are not perfect. And lalong-lalo na these are not risk-free. However, hindi rin siya basta-basta ginagawa, and they must be structured and justified and evidence-informed. Because in healthcare, doing nothing is also a decision. So HTA helps us make the best possible decision given uncertainty. So let's summarize everything we discussed today. So evidence is always uncertain. Subgroup findings are not always reliable. RCT performance and doesn't always equate to real-world effectiveness. Interpretation matters more than the raw numbers. And remember that HTA is a system we use for structured decision making. So if you just remember these 5 points, that is the core of the lecture. So I'll leave you with the final thought na lang for this line. Good decision makers do not ignore uncertainty. They don't wait for perfect data, and they don't assume everything is clear. Instead, they acknowledge certainty, they understand the limitations, and they still make informed decisions based on the best evidence that we have. And this is what exactly what HTA trains you to do. Okay? So that concludes the lecture for this video. Thank you, and I'll see you in the next session.